Dr. Kharrazian, welcome to the Digestion
Thank
Sessions.
you. Pleasure to be here.
Pleasure to have you here. Now, my presenters, I feel like most of them have learned from you. Your name has come up many times. You're super smart. You know all this stuff inside and out. You know what I'm curious about? Because I read a lot, right? What's the process like for you when you study this stuff?
The process starts with being in clinical practice. So basically I'm working with patients and situations come up where I don't have answers for them and I don't know. And that really, really bothers me. So what I then try to do is I try to go through literature search. So I just spend at least 3 full days a week on PubMed. And then I basically at this point can really speed read abstracts very quickly. And then I get the full paper. Once I get the full paper, I redraw it and put it all out. And I'm really lucky because I can remember papers from years ago and I store them really well, and then I can put them all together, and then I can kind of put the links together. And I think my contribution for what I'm told is trying to link all the different concepts and principles together and make it then clinical. So then I take the information that is reviewed through the literature, and then I apply concepts in my patients in my clinical practice. And then once I feel comfortable enough, I'll then teach it to practitioners. And that might take a year or two before I feel comfortable enough. And then once they learn it, I get feedback from them. And then I get a whole new sense of eyes because they're all trying different things and taking different observations. And then we create new clinical concepts. And that whole process takes a while.
You continue to refine it?
And it's constantly being refined, and it's constantly evolving, and it's changing. And even material, sometimes, you know, as a clinician, you look back at old patient files. Sometimes a patient, for medical reasons, needs an old file. You go back and pull it out. Maybe it's 2 years ago, and I always look at my notes and go, "Oh my God, I'm so embarrassed. I don't want to send this out." Or you even look at old papers you've written, or old books or whatever. You look back and go, "Wow, I wish I never did that. This looks so outdated."
I first became aware of you with your thyroid book.
Okay, great.
Amazing book. I love that book. And your next book was on the brain. It's Why Isn't My Brain Working? And I read that at least 2 or 3 times. Phenomenal book, well written. It's good stuff. I think everybody should read it. Why did you become fascinated with the brain?
Well, I think for me, I really don't have a personal preference. I don't really like the thyroid. I don't really like the brain. I don't really like any of this. It's just a matter of what does my patient have? I have a person who's suffering. What are they dealing with, and what do I need to know? And thyroid was one of these things where when we were working with thyroids from an autoimmune perspective, because up until my thyroid book in 2009, I was teaching that material way back in 1999. So I have seminar material from 1999 that is the book in 2009, which is supposed to be revolutionary, but we were using the model for years and years and years. And one of the things that happened is we figured out a way to really help thyroid patients, and we realized that it's not just about tyrosine and iodine and axillary temperature and goitrogen foods. This was all outdated, ridiculous information from constantly looking at lab work, trying different things and seeing patients change. So for the first book I wrote, Why Do I Still Have Thyroid Symptoms, it was really like, hey, look at this from an autoimmune perspective and look at all this research, all these things that trigger autoimmunity. Now we know these things like Th1 and Th2, and here's how we apply some of these concepts. And at that time, we were doing a lot of immunology cytokine testing, and it really helped us put it together. Now we look back and we're thinking about revising the thyroid book because we have Th1, Th2, Th3, Th9, Th21, Th22, Th17, and we're learning how to use all these things in a clinical setting. So we want to share that, but you know, everything takes time.
Yeah. When can we expect that? 2016?
I don't know.
Yeah, one day.
One day.
It will be out.
Soon, I hope.
Yeah. We're talking about the brain today. People, they've got Alzheimer's, we've got dementia, we've got anxiety, we've got depression. And you say that this is linked to the gut. Break that down for us.
So one of the most neglected things that I think most practitioners don't understand, whether they're conventional or alternative, is that there's this brain to gut access. And there's actual journals called Brain to Gut. And there's multiple papers written on so-called brain-gut access and gut-brain access. So it's in the scientific world, it's pretty prevalent area of research. But in the clinical setting, we don't have that. So we have like the average person that's into diet and nutrition, and they're really thinking of like, here's my digestive enzymes, here's my bone broth, here's my glutamine, here's my, diet, paleo diet, and they kind of live in that world, and anything that's wrong with the gut has to be an infection or food or yeast overgrowth, right? But when you work with a lot of chronic patients, what you realize is some of these chronic patients really have impairments in their brain-gut access, and many neurodegenerative diseases start in the gut. And one of the first things I think people should know about if they have a digestive order and how to clinically differentiate if the brain is involved is there a motility issue or not? Because motility is brain-based.
Define motility.
Motility means how you move foods. When do you eat something and when do you have a bowel movement, right? Mm-hmm. Do you have constipation? Do you have to drink coffee to have a bowel movement? Do you have to take magnesium or some kind of herbal laxative to have regular bowel movements, right? And if you do, that could very well be a brain to gut axis issue. Because motility, the movement of food through your gut, is really a brain phenomenon, that your brain has to fire your brainstem vagus nuclei, and your vagus nuclei then fires into your gut, to your enteric nervous system, and then you activate what are called migrating motor complexes, and then you have motility and movement. So if you have a chronic digestive issue, and part of the component to a digestive issue is you just don't have healthy amounts of bowel movements, and your digestion is a little bit slow, and you're constipated, then you got to look at this as having a neurological, or we call a neurogenic component, right?
Always, or?
Well, it's something you have to clinically rule out. It's not always, but it's like that becomes, hey, this is something I got to rule out, because if I don't, I can totally fail on this case, right? And unfortunately, many practitioners fail on those types of cases, and they become chronic, and they go from one practitioner to the next and to the next. So red flag is, hey, I have a gut issue. No one's been able to figure it out. And I've done every kind of diet, and I've done every kind of supplement, and no one can figure out my gut. A lot of those, when they have motility issues, are really brain-gut related issues. And here's the thing. When you lose motility, you don't move your food. When you don't move your food, it ferments. So you get bacterial overgrowths, you get yeast overgrowths. When you don't have gut activations from your brain, you don't release enzymes, you get enzyme deficiencies, you create the environment for parasites because you don't have enough hydrochloric acid release. Digestive enzyme release is actually brain-based. So over a period of time, if someone has a brain-gut issue, and if someone does a digestive workup where they do like a lab test, they're going to see abnormal bacterial counts, they're going to see abnormal bacterial species, they're going to see yeast overgrowth, they're going to see bacterial overgrowth, they may even see yeast infections. And obviously, you would go, well, let's go and treat all those things. The only problem is some of these patients have had all those things treated forever, and it's not helping, right?
So you're saying that the brain is where the signal comes from to get stuff moving in the intestine so things move along properly. Now, how does one rule that out?
So the first thing is, from the history, is there a motility issue? And motility issues you would look at and go, do you have to take laxatives? Do you have to drink coffee to have bowel movements? Is your bowel movement slow? How many bowel movements do you have a day, right? And that's your first clue. In a clinical setting, what we do is we listen to the abdomen. and you know, if you have a stethoscope, you can do it yourself, but you may not have the ear to know what you're looking for. So from a clinical setting, we'll actually take a stethoscope and listen to the abdomen, and then you should hear bowel sounds. And bowel sounds should have an intensity, like they kind of sound like that, and then they should have a frequency. So here's a normal bowel sound, for example, okay?
I've heard it before.
Okay,
yeah,
right?
yeah.
And then here's what you hear when you see brain-gut axis issue motility issues. You hear like, That's telling you that there's no activation going on, that those muscles are not contracting, right? The other thing we do is we look at vagal function, and vagal function clinically is you see it through a cranial nerve exam. So one of the things we look at is we look at the back of the throat and look at the palate, the punching bag, and you have these arches, and those arches are innervated by the vagus. And if the vagus is failing, which is the area of the brain that fires into the gut, when people say, ah, and their arches should move with the punching bag in the middle,
Right.
It doesn't do that. It's just,
uvula, right?
So the uvula, right? But we're not really concerned with the uvula. We're looking for the arch.
Gotcha.
Sometimes if it's really bad, you'll just see an arch totally fallen, and when they say, ah, nothing moves. Sometimes when they say, ah, nothing moves. And other times, when their brain is starting to degenerate, neurons, when they start to degenerate, come closer to threshold, so they spontaneously fire on their own. Sometimes when people just say, ah, and stick out their tongue, they start going into a gag reflex. Or sometimes you can, you can't even get a gag reflex with people. And sometimes you just touch the tip of their tongue and they already start having a gag reflex. And people call those exaggerated gag reflexes at times, but they're not always exaggerated. Those are sometimes developed over a period of time as the area of the brainstem where the vagus is degenerated. So we look at their history for motility. We'd expect if the motility is wrong to have all the digestive enzyme, leaky gut, bacterial yeast overgrowth in the history comes with it. And then we listen to their bowel sounds clinically, see if those are okay. Look at their uvula and their palate and see if they're having activity there. We look at gag reflex. And if those are impaired, we know that there's a brain to gut axis issue. And there's probably a handful of people in the world that do that. And people that do fix chronic gut patients.
I remember from your book, gargling and singing.
Right.
are good for getting that vagal tone or getting that going again, right?
Right. So my book, my brain book that I wrote, I have a whole chapter on the brain-gut axis, and I'm trying to get this information out to as many people because this without question works. We've really been able to help a lot of chronic gut people that have this. So here's the first thing. If a person has a brain to gut axis disorder, they're not going to fix it with digestive supplements for their gut. They may still need it to function properly because their brain isn't making them produce enzymes, so they may need to take enzymes. Their brain vagus isn't firing, so they can't get blood for the gut, so they have leaky gut. So they'll probably feel better taking digestive support and changing their diet and having a clean diet so they don't have as much inflammation and bloating and swelling, but that's not going to fix it. They have to start from brain down. And when you look at supporting from the brain down, you really can't just do it with a supplement. You have to develop plasticity. You have to develop connections, right? So neurons have to fire into each other for you to have your brain fire into your vagus to fire into your gut nervous system, and then for those migrating motor complexes to work. And that neurological firing pathway not only helps motility, but it's the pathway that helps you neurologically release enzymes, and neurologically fire your parasympathetics to get blood flow to your gut.
I want to back up a little bit. Migrating motor complex. Dr. Siebecker covered that, but just in case somebody didn't watch that, what does that mean?
So the migrating motor complex are just a group of what they call motor neurons or muscle neurons, and your intestine cells have what they call smooth muscles, and those are the neurons that cause you to have your intestines contract and move, and control your bowel function. But that's all controlled by brain function, right? So if you have a person who's lost their brain-gut axis, we clinically know we can't just have them take a digestive supplement to treat it. And we go into 3 main things we do, and I cover this in my book. One of the first things we do is we have people gargle. And this is something that was done in the functional neurology world for a long period of time with people that had head injuries and things like that. But gargling, as you take water, put it in the back of your throat and go, you fire those palate muscles, which are fired by the vagus. And the key thing when we have patients do it is they sometimes understand the intensity they need to do it. They need to basically do it to the point they're tearing, you know? So it's not like, ugh. It's like they take the water back and go,
you're working it out.
Yeah, and then the area of the vagus is right next to an area called the superior salivatory nucleus, which causes you to tear. So if you hit the brainstem aggressively enough, you'll start to see the tearing. So we ask patients to gargle aggressively enough until they have tearing. And if this area is a part of the brain that's not functioning well, it's degenerated, they're going to have a really hard time gargling. Or they may be a gargle for 3 or 4 seconds, or they just may choke, spit it out. So they may have to, start with a small amount of water and kind of build up. And over time, they can do it for several minutes really aggressively, and they're tearing and they're tearing and they're tearing. And that's like how you activate it through, an activation pathway. The other thing we have patients do is we have them go to Amazon and buy like a box of tongue blades and induce a gag reflex, not in the back of their throat so they don't injure themselves, but just to push down on their tongue. If they push down the back of their tongue, they'll feel like a little gag, and their eyes will start to tear. As they do that, they're actually firing that pathway. And it's just like having a weak biceps. If you have a weak bicep, you have to activate it by doing curls. If you have a weak vagus brain-to-gut connection, you have to activate it to really develop those connections and get that plasticity going. The third thing we do, and this is really important, is we have patients do a coffee enema, but not for detox reasons. We want them to do a coffee enema, and the coffee has the caffeine, and the caffeine stimulates gastrointestinal nicotinic cholinergic receptors. So it makes their gut kind of move. That's why a lot of people that are constipated do coffee enemas. But we want them to get enough coffee and saturate it enough so that they have to force themselves to suppress their bowel movements. So if they lay on their side and do a coffee enema, they might have this urge to have a bowel movement. And if they don't have an urge, we need to have them increase the concentration of the caffeine in there. And then they just hang out there for as long as they can, suppressing their urge. And as they suppress their urge, they're firing their frontopontine vagal enteric axis. And if they keep doing that, they build endurance in there and they start to regain their brain-to-gut access, right?
You just hold it as long as you can?
You hold it as long as you can, and then you concentrate it as long as it can so it becomes difficult. It's like kind of adding plates to your bench press, right? You have to increase the intensity to make yourself work harder. So those 3 things we do seem to have a really good impact on impacting brain-to-gut access. At the same time, we want them to have a clean diet and take digestive enzymes and support their intestines because we don't want the inflammation there because the pathway goes from gut to brain as well. But the most area that's neglected with a lot of chronic digestive people is failure in their brain-to-gut axis. That's why I wrote a whole chapter about it in my book.
Going back to gargling, several times a day, are they doing this?
Right. So the key thing is to do it multiple times a day. We have some patients, we say, listen, every time if you watch TV, every time commercials come on, if you read a book, every time you finish a chapter, every time you use the restroom, gargle, just so it becomes part of a routine thing. If you ask a patient to just do it several times a day, they don't remember. So we try to correlate it with something they do. Like I just saw an athlete, college football player, and he's eating like 2 hours a day. Every 2 hours he's eating. I go, great, every 2 hours I want you to do your brain exercise. He had a different area than the gargling, but it was just a way to remind him to do it. But usually if they can get in a dozen times a day, because they don't take that long, you do it for like a minute, right? It's not like you're working out and getting exhausted afterwards.
Gotcha.
Right.
Tongue blade as well, several times a day?
Yeah.
Gotcha. Coffee enema daily?
Yeah, once a day.
Gotcha. Okay. And hold it as long as you can.
Yeah.
All right. Good stuff. How common is this? Brain issues being involved with the gut?
It depends. If you see the average patient, it may not be that common. If you see chronic patients, it's very, very common. If you see failed patients, no one's been able to help. It's one of the most common things you see because this is an area that everyone overlooks.
Was I wrong about the singing thing? Was singing actually part of the treatment?
That's another thing too. Thank you. Singing, another way you can activate the vagal muscles in the back of your throat is if you sing really loudly. And it's, it's fun for people to do that as well.
Okay, gotcha. So again, brain signals coming from the vagal nuclei, was that it?
So here's how this works. You have an area of the brain, the frontal cortex, that's where you have motor activity, that fires into your brainstem vagal motor nuclei, that fires into your enteric motor system. You also have brain fibers from other parts of your brain called the insular cortex that fire into somatotopic areas and autonomic areas that control your blood flow and digestive enzyme secretion. But I kind of wrote them out in the book. I don't know if people are interested in the...
Oh yeah, they're interested in all that stuff.
Okay, sure.
Get the book.
No, but even you can, whatever you want to talk about. We can
Gotcha. Okay, and so if that's not firing properly, you said that won't fire the enzymes as well?
Right. Okay. So as you look at brain activation through the hypothalamic areas of the brain, through the insular cortex areas of the brain, they fire into a brainstem area called the nucleus ambiguus. And the nucleus ambiguus is an area that controls autonomic function to the gut. So you have sympathetic function and parasympathetic function. So parasympathetic function for the gastrointestinal tract is going to cause blood flow there. And it's going to cause digestive enzyme release. And it's going to cause motility. It's going to cause valves functioning and doing their things the right way. So there's brain control for not just motility, but digestive enzymes and blood flow and circulation issues.
Okay. Let's go back to the motility issue. The motor complex, migrating motor complex. I talked about that with Dr. Seebecker.
Great lady.
Yeah, she's awesome. She's super smart and lots of energy. I think that was my longest interview because she was going. Yeah, it was awesome. Now, you've kind of covered this already, but I want you to go into it again so it really sticks. Talk about what the brain has to do with SIBO.
Okay, well here's the thing. Small intestinal bacterial overgrowth is one of these things where it's becoming much more popular. And the thing with it is, the concept is you lose your bowel function and your bacteria that's in your large intestine starts to migrate into your small intestine, and then you have this abnormal small intestine bacterial population. And then the bacteria in the small intestine is very reactive to yeast and galactans and other types of probiotics in foods, and people will eat something with a little bit of starch in it or a little fiber and they get severely bloated, right? But it initially starts with a dysfunction in the migrating motor complex. It starts with a function in valve control, which is all neurogenic based. This is why I get so frustrated with the world of SIBO right now. I'm going, listen guys, look at the mechanism of what causes it. It's a valve dysfunction and a migrating motor complex dysfunction. This is a brain-based phenomenon. Now, it's not all related to the brain failing. Sometimes the gut nervous system fails because the gut nervous system is an area where you have neurodegeneration too. Just like the brain can degenerate away, the gut nervous system can degenerate away too. So whenever we see a patient that actually has true SIBO and they have the diagnosis, we're pretty much looking with the majority of them having a degenerative neurological gut issue or a brain-to-gut access issue. I mean, there's some people that have SIBO from surgeries and anatomical things, but for the most part, when it's developed without surgery, we pretty much know those are the main things. And if we just to sit back and do a neurological exam on them, or just to sit back and just evaluate them, you can see many of them have early signs of Parkinson's, many of them have had traumatic brain injuries, and 2 years later they started. And it's one of the other most common missed things when you work with chronic patients.
If I remember correctly, I believe she said that there are particular drugs that help to stimulate that,
Right.
that motor complex. Now, can you get rid of those and not use those by training the brain?
Right, exactly.
Okay.
So in the conventional world, they use prokinetic drugs.
There you go, that's the word.
And these drugs are there to stimulate acetylcholine receptors or dopamine receptors or serotonin receptors as an attempt to make gut motility happen. And then they give them antibiotics that don't get absorbed so they can kill the overgrowth. But the effect of treatment is very, very poor when you look at recurrence rate. There's almost 100% recurrence rate, so it doesn't fix it, right? And then at some point, with any type of neurotransmitter stimulating drug, whether it's an antidepressant or a prokinetic, neurotransmitter receptor sites develop resistance to it, and they just stop working, right? And this is what's so frustrating. It's like, fix the problem, fix integration, right? So simple things like gargling, simple things like singing, coffee enemas where you hold it instead of just trying to do a detox with it and have an immediate bowel release. Tongue blades, gag reflexes. Yeah. Those are really, really key things to try to rebuild that system. Here's the deal though. Unfortunately, there are some people that are so progressed neurologically that their gut has so degenerated away so far, you can't do much. That's why early treatment, early identification treatment is really the best chance you have. Just like with all brain degenerative disorders, you really want to see the early signs of Parkinson's with someone and immediately start doing things for them. As soon as you see a child have autistic behavior, you want to go in there and start doing stuff with them. Because there's also what's called negative plasticity. As time goes on, you get abnormal firing of pathological pathways, and as time goes on, neurons die off, and then there's less potential chance to make connections with them. So you gotta catch it early, and if you catch it too late, there is a point of no return.
I feel like we're always looking for foods and supplements that are going to help. Are there any foods or supplements that can help stimulate the brain?
Yes. So at the end of the day, when you look at anyone who's got a brain-to-gut axis issue, the reason they have it is usually because their brain is really the problem. That the brain is really what's degenerating, or their gut is starting to regenerate. So let me kind of give you some of the most common examples. Parkinson's disease, for example. One of the most common diseases out there, neurodegenerative diseases, and when we say Parkinson's, everyone is always thinking that it's older people, but about 15% of, sometimes even say 20% of people that Parkinson's start at early onset Parkinson's, so they're before age 35. So it happens in young and older people. Yeah. But Parkinson's disease starts in the gut. And Parkinson's disease, people think of it as the area of the brain called the substantia nigra where dopamine is failing to deplete. That's not what Parkinson's is. Parkinson's is what they call an alpha-synucleinopathy. This is where a protein called alpha-synuclein builds up in between nerves, and the nerves can't communicate, and then they start to degenerate off. But the alpha-synuclein protein buildup that then leads to degeneration starts in two places first. It starts in the gut, so people start to get gut degeneration, and then it goes into the olfactory bulb, so people lose their sense of smell. And they don't lose it completely in initial stages, they just aren't as sensitive to smell. And when they lose their sense of smell, they lose their sense of taste. So whenever we see a person coming in and they're complaining of stiffness, which is one of the early signs of Parkinson's, and then we talk to them and they just say they don't enjoy eating anymore, nothing really tastes good, they don't have any joy with that anymore, or they don't really know what's that, but they just don't like to go out anymore to eat or do anything. And we see they have constipation and have to use enemas and things like that and to get bowel motility. That's sometimes the earliest presentation of Parkinson's disease, right? Mm-hmm. So sometimes with these disorders, what we're really seeing is an early neurodegenerative disease. And that takes an aggressive approach for brain other than just like taking a supplement. And in my brain book, I cover 20 different chapters to kind of try to address all the different things that can be involved whenever you have a brain failing like Parkinson's, to try to get it to function better and slow down some of the process. Other times, the brain-gut axis issue isn't because the gut's degenerating first, it's because the brain is degenerating. And this is with things like dementia, What people may not realize is when they, have a hard time with directions and it's getting worse and they can't find their phone and they can't find their keys all the time and have to write everything down, those are all early dementia symptoms. Mm. And that's that's one of the other second major neurological diseases. And as the brain starts to degenerate, the majority of the brain's output is to the pontine area where you have the vagus. And so as you get neurodegeneration, you get less activation to the pons, and then you start to get gut functions. As a matter of fact, 90% of the brain's output, not input, but output, is to the pons. And in the pons you have your vagus. So with almost every neurodegenerative brain disorder, you start to have failure in the brain-gut axis at some point.
Mm-hmm. What would be like those top supplements that can help to
support the brain?
Support the brain, yeah.
Okay. Well, as far as supporting the brain, the top supplements you first of all, we always start with diet, but clinically we start with diet, but let's talk about food. I mean supplements. Supplement-wise, the basic things are, here's the thing. It's a tough question you're asking me because that's not how we think. We kind of, like the way I try to teach it to people is through my book, in the sense that in the beginning of each chapter I give a list of symptoms. So here's all the symptoms of neuroinflammation, and here's all the symptoms of low oxygen to brain, and here's all the symptoms of low blood sugar to brain, and then we kind of look at it from that perspective.
Gotcha.
So it's not that.
So it's specific to the person.
But if I were going to pick one,
okay.
If I was on the spot to pick one, I'd say the vagus is an acetylcholine-based pathway. The gut motoric system is predominantly acetylcholine, and botanicals that can improve acetylcholine activity can have the just a first guess effect. Huperzine being one of them, galantamine being the other one, and what they do is they increase the sensitivity of the acetylcholine receptor, and they inhibit an enzyme called acetylcholine esterase. And what that does is it allows acetylcholine to hang on in between neurons, the synaptic cleft longer, and makes the receptors more sensitive. Sure. So some people, if they're just struggling and they need to do something to get their vagus to fire more, their brain to fire more, their gut to fire more, they can take things like huperzine or galantamine. They're over the counter. There's no major side effect for most people, and there's no withdrawal response where if they stop taking it, they have any problems. It's just, you can try it. But there is a dose they have to find out. So the dose is not based on body weight, and it's not based on age. It's just you start with one and you see if you get an effect, and then if you get an effect, you increase the dose till you get a maximum therapeutic effect. Because there'll be a point where if you take 6 capsules versus 5, you don't notice any benefits, right? But you may not really feel it at 1, so you got to get to 3 or 4 before you feel it, and 5 is where you have the best effects. That's how we support the brain nutritionally.
It was huperzine and what again?
Galantamine.
Those are good. They're going to fly off the shelves now.
Well, galantamine is getting harder to find because it's also classified as a drug.
Oh.
But with the FDA guidelines, is it being a natural supplement. So what's happening is some manufacturers are just not carrying it anymore because they don't want to have any FDA issues. Because it fits the label as a drug and it fits the label as a natural supplement. It's the most common used treatment for dementia and Alzheimer's in the world, but not in the US. So in most countries they use galantamine, and it's just a botanical and it's pharmaceutical based, and that's what they give to dementia patients.
It's too bad it's not used here. I want to get to diet.
It is available, but it's harder to find.
Gotcha. I want to get to diet a little bit later.
Okay, sure.
Let's go into the brain's impact on leaky gut. How are those connected?
Okay. So there's been some really interesting studies done with brain and leaky gut. And, we call it leaky gut. In the literature, they call it intestinal permeability. That's why when we have some people go, hey, there's no research on leaky gut, because they do a literature search for leaky gut and they don't find any papers, right? So if you're doing a literature search, look for intestinal permeability. But with intestinal permeability, there's research now, and they've done a lot of animal studies, and they have to be animal studies, where they induce traumatic brain injury, and they can measure leaky gut within 3 hours. And this has been repeated with at least a dozen studies now.
It happens that fast, 3 hours?
It happens that fast, yeah, immediate. Sometimes even sooner in other papers than 3 hours.
And what are they doing to make that happen?
Well, they're actually taking a control group and looking at their gut, and taking another group, and then they're using traumatic brain injury. And then they look at their gut within a few hours later, and they start to see when they start to develop leaky gut. Their intestinal permeability changes. They did one paper, which is the breakthrough paper, and they did this with rats. They took one group of rats, and they caused a traumatic brain injury, knowing they were going to get leaky gut. They took the other group, caused brain injury, but they electrically stimulated their vagus. And when they had electrical stimulation to their vagus nerve, none of them developed leaky gut.
So the brain injury is causing some vagus.
And that was the paper that really defined it is the vagus activation that is not being activated, it's causing leaky gut. And it really, for us, it reaffirmed the fact that, hey, when we have people gargle and we have people activate their vagus and do those things, this is, we clinically see it work, but this is a great paper because it connected those two. So those studies are really interesting because with acute brain trauma, you see connections really quickly because you have an immediate dramatic loss of brain function, and then you see what happens, right? But people sometimes don't have an immediate loss of brain function. They have a neurodegenerative process which happens slow over time, but the same consequences happen. As the brain starts to fail and not function, they can't fire into the vagal areas, and so you get leaky gut and those types of things as well.
I can't help but think about football players. They get head injuries all the time.
Yeah.
Causes issues with the vagus nerve.
Yep.
That can cause digestive problems,
That's
as
right.
well as intestinal permeability, which can lead to dementia and other brain issues, correct?
Absolutely, and that's published. And they do have human studies on that. And what they find is human subjects that go into traumatic brain injury also have intestinal permeability and leaky gut. And what they've also found is with traumatic brain injuries, not only do you get a leaky gut, but you get immediate inflammatory reactions in the gut. And if anyone works with traumatic brain injury people, I do all the time, they almost all have chronic gut issues. And here's the problem. They'll go see someone and go, well, the gut's going to fix the brain, so let's put you on a probiotic and let's put you on this. And you're like, whoa, 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 we got to treat both.
Right. So I want to make sure I'm clear on this one. So the vagus nerve, what does that have to do with how the intestinal lining builds itself? Like with the cells that are going on there, that
So the vagus nerve has a motor component, which you have motility,
right.
and it has an autonomic component, okay? The autonomic component is what allows you to have blood flow to your gut.
Okay.
Don't forget, your blood carries everything to your gut. All the digestive supplements you take, all the foods you take, all the things to heal your gut, get there by blood.
Okay.
So if you lose the ability to get blood to your gut efficiency, you're not gonna get any of your nutrients to your gut, right? So that's the first kind of basic thing. Also, to regenerate cells, you have to have growth factors and hormones and other things get to your gut. Testosterone, progesterone, estrogen, thyroid hormones, they all cause your gut to repair, as well as other peptides. So as blood flow becomes compromised from lack of vagal activity, you lose the ability to give your gut what it needs to regenerate. So that's why we see so much leaky gut issues with people that have either traumatic brain injury or neurodegenerative changes in brain. This is what we see with autistic kids. Autistic kids have brain development issues, and everyone thinks, well, it's a gut issue that's causing autism. And of course, everyone sees connections between gluten and dairy, but you see very few autistic children really have their brain treated well, you know? They kind of just get like a fish oil or,
right.
you know, and unfortunately, if they can't treat their brain-gut axis, there's a problem. And if you don't treat the brain-gut axis, then you have a gut-to-brain axis, because as the gut starts to get inflammation and create these inflammatory reactions, those inflammatory reactions in the gut have an impact on brain, and this is what they call the gut-to-brain axis. Right. And this is where inflammatory cytokines, inflammatory messenger chemicals cross the blood-brain barrier, and they actually stimulate cells in the brain called glial cells, and that creates a brain inflammatory cascade, right? And some papers in the celiac world are showing is as you get a intestinal permeability, you release something called zonulin, and then zonulin actually opens up the tight junctions of the brain. So what we're actually seeing is some of the research showing that leaky gut leads to leaky blood-brain barrier, and gut inflammation leads to brain inflammation.
Back up on that real quick. I want to make sure everybody gets this part too about the zonulin thing.
Sure.
What is zonulin's role in the gut?
Okay. So zonulin was something that researchers figured out when they were studying cholera, and they're looking at why people that have cholera have this intestinal permeability developed. Some researchers identified it was zonulin. And then what they started to do is they took this zonulin, they purified it into a protein, and they injected it into animals, and all these animals got leaky gut. And then what they found is that zonulin is a protein that binds to a zonulin receptor and opens up the intestinal cells. Okay. So when you look at leaky gut, there's two types. There's what they call transcellular and paracellular. So you have these, like it's a picket fence. You have boards that are horizontal, and you have horizontal, and you have boards that are vertical. You can have inflammation and destruction cause leaky gut by just destroying the gut. That's what they call transcellular, right? So chronic inflammation just destroys the lining of the gut, and then goes through the horizontal boards of like a fence, and that's one version. That's one mechanism of leaky gut. Then you have paracellular, where the board in between the horizontals or the tight junctions open.
And zonulin?
And zonulin binds to that, and then they open up.
Opens up. Okay, cool. And then it also does that in the brain as well.
And it does it in the blood-brain barrier.
Creating the leaky brain.
Leaky brain.
Okay.
And what's very fascinating now is there's numerous papers coming out showing that people that have inflammatory bowel syndrome have white matter lesions in the brain.
What does that mean?
What that means is their gut inflammation is causing brain degeneration.
Gotcha.
That the gut inflammation is starting to cause destruction of myelin, the sheath around their nerves. And this is a degenerative process. So Now, in the functional medicine world, there's a saying, fire in the guts, fire in the brain. And that's been a common thing everyone's known. But now in the literature, they're showing very, very high statistical rates. And when they do logistic regression studies and they evaluate people that have IBS, they have severe MRI brain changes.
How does one test for that, for leaky gut?
For leaky gut. So the way we test for leaky gut is, for me personally, I like to check both transcellular and paracellular ways. And we do that through Cyrex.
Okay,
and
Cyrex, which?
Cyrex Labs, it's called array number 2.
Array number 2.
And if occludin zonulin antibodies are elevated, then we know it's paracellular. And if it's transcellular, actomyosin antibodies are elevated.
Gotcha.
And some people have both, and some people have one version.
And that leaky gut test gives you a good idea if you have leaky brain.
Right.
Right. You also mentioned in your book GABA, right?
Right.
If you take GABA and you get an effect from it, it could be leaky brain.
Right, so talking about this gut-brain connection and leaky gut, leaky brain, we talk about in the Brain Book a chapter on this, and we talk about how we use GABA. So in the past, in the leaky gut world, the way they used to test for it was they did a test called the lactulose mannitol test. And the lactulose mannitol test is where you have two sugars, lactulose, which is a very large sugar that shouldn't be absorbed, and mannitol, which is a very small sugar, right? Well, lactulose is so large that it shouldn't go through a healthy intestinal tight junction. So what they used to do is they used to give people a load of lactulose, and they would check their urine, and if there were high amounts of lactulose in the urine, they'd go, wow, that large particle got through, now it's in your urine, so you have a leaky gut. That was the older test. The Cyrex test is much more advanced now, much more reliable than that, right? But that led us, clinically, before we were able to test the blood-brain barrier objectively, is how do we do that with blood-brain barrier? So we realized that clinically, we realized that a lot of our patients would take GABA, and some would not really notice anything, and some would. And GABA, aminobutyric acid, is a over-the-counter supplement, right? So GABA, the molecular weight is large, it's huge. Mm-hmm. And what you cross the blood-brain barrier are nanoparticles.
Right.
So if someone takes GABA, and it actually has an effect on the brain, that it had to have crossed the blood-brain barrier. Right?
It's too big. It shouldn't be able to fit through.
It's too big.
Gotcha.
And there's no transport mechanism with GABA into the brain. There's transport mechanism with GABA out of the brain, but not into the brain. So that was our test. We were trying to mimic the lactulose test with leaky gut. That was what I was trying to do, because I was trying to figure out what's going on with my patients. All right? And then we started teaching that, and other people started doing it, and it was a really cool way to do it. So what we do is we'd have a person take 1,000 milligrams of over-the-counter GABA, and then see if it affects the brain. And if it affects their brain, they feel really sedated and calm or relaxed. Sometimes people get a paradoxical response, they get hyper. But either one of them means it had an effect on brain. So there should be no effect with 1,000 milligrams of GABA. And if you take GABA and it makes you relax and calm down, you probably have a leaky blood-brain barrier. In recent years, Cyrex Labs, under the work of PhD researcher Rista Vijdani and papers published on this, now there's objective ways to measure blood-brain barrier. Antibodies. So Cyrex has a blood-brain barrier antibody test, okay. Array number 20. So now we can check leaky gut with lab, and we can measure leaky blood-brain barriers, and we see a pretty high correlation with the two of them.
Taking GABA, is that a good way to check your progress?
Right, and here's the thing we do. If we see someone that does the GABA challenge instead of the lab test, and they feel they have an effect, we don't want them to continuously take it, even though they may feel great and relaxed taking it. We want them to put it away. Mm-hmm. Because we don't want to sensitize the receptors in the brain. And then after like a few weeks, we'll have them try it. So here's a great example. Gluten sensitivity people usually have leaky guts and leaky blood-brain barriers. They find out they have gluten sensitivity. They fail the GABA challenge test because they take it and they feel totally sedated for a few hours. Mm-hmm. We have them go on a gluten-free diet for 6 weeks. We have them do the GABA challenge test. They have no effect anymore.
Got it.
So then we go, hey, your gut and brain are doing better.
Very cool. I want to rewind again. You talked about inflammation firing up the glial cells in the brain.
Right.
And if I recall correctly from their book, because I read it 2 or 3 times,
thank you.
You said the glial cells are hard to turn off.
Right.
Talk more about that, and is it possible to turn them off with supplementation or something?
So, when we look at the immune system, we have an immune system that's different in the brain than the rest of the body. The rest of our body, we have T cells and B cells and natural killer cells and all these variations of cells. But in the brain, there's only one immune cell, and it's the glial cell. And there's subtypes. There's astroglial and microglial, right? But for the most part, there's just glial cells, and that's it. And glial cells don't shut off. There's no turn-off mechanism. In the rest of our immune system, we have cells called T suppressor cells that once we fight the infection, T suppressor cells come in and they go, hey, fight's over, calm down, you don't need to fight anything anymore, and our whole body stops becoming inflamed and we're cool. But in the brain, there is no T suppressor cell. There is no off switch. So once a person gets brain inflammation, you get a cascading event. And whether it's traumatic brain injury, and they call this in the sports medicine world post-traumatic inflammatory encephalomalacia, that they get an injury and the inflammation then leads to a domino effect, or it's chemical issues like IBS, that the inflammation from the gut turns on these glial cells. Those glial cells keep going until they die off. But before they die off, they recruit other cells, and then they recruit other cells, and they recruit other cells.
It sounds like really bad news. How do we shut it off?
So here's the thing. If you do a literature search, there's no drug that shuts them off, but there's natural supplements in the literature that shut them off. Resveratrol has been shown to shut it off. Turmeric has been shown to shut it off. Luteolin has been shown to shut it off. So there's a list of these, and in the Brain Book I go through I cite the major studies on it and show the references. So this is one of the areas where, like, if you really have a brain degenerative process, first of all, the pharmaceutical world, whatever it is, has very little options, and natural medicine has unbelievable options. And this is what's really upsetting, because people aren't getting the science. They're getting a mainstream pharmaceutical model. And this is what really, I don't know, pisses me off about the average neurologist. Like, listen, your job is to lead the literature on everything related to neuro, and you're too biased to look at natural supplements in food, so you're not serving what you should be serving as an expert. And this is what's so frustrating, because the evidence is all there, and no one's doing it. And this is something that people can do very easily. It's very inexpensive. They can go and start taking it. When people do get brain inflammation, what happens is nerve conduction goes down. So their brain speed goes down. So the most common thing we see with people that have brain inflammation is they just feel brain foggy, and they can't find words, and their mental speed is reduced. And one of the diagnostic things is, if you have a brain inflammation issue, is when you start loading up on like turmeric and resveratrol, if your brain speed immediately changes and the world lights up, that's kind of diagnostic that you probably had some glial activation issues, right? Because everything's a working diagnosis until something actually changes it. And then you go, oh, that's more likely the diagnosis.
This is great information. Talk about the connection between brain, the gut, leaky gut, and autoimmunity.
Okay. So this is a very, very important question that you bring up here. And first of all, traumatic brain injury people all the time develop autoimmunity, okay? And one of the things that we know is that the brain and gut and brain are, first of all, feedback access, that these things communicate on a regular basis, that we have gut peptides like CCK and different digestive enzymes and different proteins in the gut, and cytokines and neuropeptides of the gut that actually communicate with neurons in the brain. And so we have this neurochemical neurotransmitter feedback going back and forth on an ongoing basis, right? And when one area starts to dysfunction, other areas dysfunction. And that's pretty well known in the scientific literature, maybe not in clinical practice, either both medicine and alternative. But in the scientific literature, it's pretty well known. So one of the other things we see is that when this axis starts to fail, and this axis can start to fail from either the gut failing first or the brain failing first. So if the brain fails first, then you don't get vagal activity, and then you get low motility, and then you don't get blood flow to your gut, and you get a leaky gut, and you get an inflammatory reaction, right? Now, that inflammatory reaction and the leaky gut makes the person overzealous. And now there's multiple papers in literature that show in animal models, if they induce leaky gut, they can develop autoimmunity. Most of that's done with zonulin and type 1 diabetes, okay? But on the other hand, if someone, unrelated to the brain, if someone has a bad diet, and they're like sensitive to gluten, and they eat the standard American diet, and they're eating fast food. If you eat the standard American diet, you have a leaky gut promoting diet, okay? So if you have that and you have a chronic inflammatory cascade in your gut, and you just have unhealthy gut bacteria, your gut starts to break down and fail. And then you start to get leaky gut. And then the inflammatory reaction from the gut ends up turning on glial cells in the brain, and the brain starts to fail, and then you get this brain to gut axis web failure. So there's this interloop between the two. And chronically, when this becomes chronic, what we typically see is people develop autoimmunity. And as people lose their brain to gut or gut to brain axis, and they get intestinal permeability, the most common food that they react to are GMO food, soy, and hybridized foods like gluten, right? Both of those are considered neuroproteins to the immune system. So That's why people feel better on a paleo, older type diet, because these new proteins tend to be the most immune reactive, and as you lose your tight junctions, you create this inflammatory vicious cycle. So what we typically see is whether the gut fails first or the brain fails first, you lose the access. And then once you lose the access and you have chronic inflammation and you have chronic intestinal permeability, that sets up the stage for autoimmunity.
Define real quickly for those who may not be familiar with it, what autoimmunity is.
So autoimmunity is a condition where your immune system starts to attack yourself. Mm-hmm. And in immunology, they refer to it as a loss of self-tolerance. So you should tolerate yourself. You shouldn't attack yourself. Your immune system should know that your tissues are your tissues and they're not your enemy. Mm-hmm. So what happens in autoimmunity is your immune system loses that self-tolerance. And we know leaky gut is one contributor to it, but we also know that chronic inflammation, this regulates things called Treg cells, and those Treg cells failing are one of the key cells that allow us to have self-tolerance. And then as people start to get more intestinal permeability, they get more inflammatory reactions and more of an overzealous immune system, then they lose their chemical tolerance, then they react to chemicals around them, whether it's gasoline fumes they can't handle anymore or perfumes. And then all those things become triggering events that make their immune system crazy. Now their immune system is attacking their own tissue by making antibodies for their thyroid, or antibodies for their brain, or antibodies for their adrenal glands, or whatever they are. And now they're in this vicious cycle of brain-gut access, leaky gut failure, and an autoimmunity on top of it. Mm-hmm. And that is very common in chronic people.
How does somebody test for that?
For autoimmunity? We test for autoimmunity by doing what they call autoantibodies. Autoantibodies are antibodies to yourself. Mm-hmm. That's where the word auto, self, antibody comes in. And for me, I use Cyrex, mm-hmm. and I consult with Cyrex, and I work with them on a regular basis. But I think they're the world's leading autoimmune immunology lab. And they have a panel, which I use on a routine basis with anytime I suspect autoimmunity. It's called Array number 5. It's their multiple antibody screen. And it checks for antibodies against all the major tissues: stomach, intestine, thyroid, joint, liver, adrenal, nervous system, heart, platelets.
Is that also called the predictive antibody test?
Yeah, and the word predictive antibody has come up because researchers are now finding that when you start to make antibodies, it's not benign, that it actually is predictive. So there's research showing, for example, if you have thyroid antibodies, you're going to get Hashimoto's in your lifespan. Yeah. Some papers have shown if you have islet cell antibodies and GAD antibodies, within a period of 5 years, you will become type 1 diabetic. So in the past, they used to think antibodies didn't really mean anything. Now here's the thing. Someone can have their brain fail, their gut fail, be in this gut-to-brain vicious cycle. They start to go into losing their self-tolerance, and they start to make antibodies. Yeah. Then whichever antibodies they make, and no one knows why you would make antibodies specifically to one tissue versus the other. There's multiple theories, but no one really knows for sure. But then you start to make antibodies, and the antibodies can now be to your own gut, it could be to your own brain, or it could be some to your own thyroid.
They can be to estrogen, correct?
Yeah, it can bind to estrogen.
Ovaries.
Causing
reproductive issues.
Yep.
Yeah, I think you mentioned miscarriages in a talk that I was at. Right?
Yeah, years ago when I used to work with a lot of infertility patients, we would find a lot of them had antibodies to their own ovaries, and at that point we were able to commercially test through a lab called Immunosciences antibodies to their own estrogen and progesterone, and it can lead to chronic infertility. Again, as this brain-to-gut vicious cycle fails and someone loses their self-tolerance, mm-hmm. The next thing that happens, they get autoimmunity. Then the autoimmunity creates its own whole complex list of symptoms. And then for them, they may be the reproductive areas they're finding. So then they have chronic infertility and they don't know why. Right. And for someone else, it could be, their brain, and the brain's degenerating really, really fast and they don't know why.
Last topic I have for you is gluten.
Yeah.
How does that impact the brain?
So gluten, first of all, cross-reacts with brain. And that's one of the key things. That we know that gluten is very inflammatory. But in immunology, there's a concept called molecular mimicry, or cross-reactivity. And this is where, when you look at the amino acid sequence of a protein, you can see it has its own unique blueprint. But if 3 amino acids are identical in a sequence with something other protein, then antibodies from one protein can bind to another. So gluten antibodies have been shown to be similar to areas in the brain. Gluten has been shown to directly bind to cerebellar Purkinje cells because of that amino acid sequence being so identical. Gluten has been shown to bind to synapsin, which is a protein in all your neurons. Mm-hmm. And part of the reason why gluten is so dangerous is that when an antibody is bound to a tissue, the immune system has to destroy it. So for example, if you're gluten sensitive and you eat gluten, your immune system goes, wow, we don't like this protein, we're going to react to it, and then make antibodies, and then those gluten antibodies attach to the gluten, and then your immune system just destroys it, and then that's where you get the inflammation from because the immune system is all revved up. But these gluten antibodies not only attach to gluten, they actually attach to brain. Brain cerebellum, Purkinje cells, that creates a severe inflammatory reaction. And then overall, just the overall systemic inflammation from gluten sensitivity does create brain inflammation, right? And now they're showing in the celiac disease literature that gluten triggers zonulin release, and zonulin opens up the blood-brain barrier. So think about this. If you're gluten sensitive and you eat it, you get antibodies to gluten, you get a systemic inflammatory reaction, you release zonulin, now your blood-brain barrier is open, now you get an influx of inflammation to your glial cells, now you have your brain on fire, and then your brain starts to degenerate, and as your brain degenerates, your gut starts to degenerate, and you get this brain-to-gut axis inflammatory reaction.
Sprouted wheat bread, people think that that's better for them.
It's not.
WGA?
Yeah, so one of the other things, and we cover this in my third book coming out, Gluten, Leaky Gut, and Autoimmunity, is it's not always gluten. Sometimes it's wheat germ agglutinin. And sprouted types of grains have the highest amount of wheat germ agglutinin. And papers have been published that show that antibodies to wheat germ agglutinin bind to neurons and they suppress nerve growth factor release. And they basically create their own inflammatory destructive process. So you could have a person who may go, hey, I've been tested for gluten and everything's okay, I don't have gluten antibodies, but they've never been tested for wheat germ agglutinin, and they're eating sprouted grains, and all of a sudden their brain's failing away on them. They don't know why.
Mm-hmm. And that would be the Cyrex test again.
Yeah, so we use Cyrex Array 3, and that checks wheat germ agglutinin in the whole spectrum of gluten reactions. And as we talk about brain and gut, recent research has showed there's 3 different enzymes for gluten sensitivity. Or celiac, transglutaminase 2, which is intestinal, transglutaminase 3, which is skin, and transglutaminase 6, which is brain. And now papers are showing, like one paper recently showed that when they check people that have reactions to gluten, 20% of them have transglutaminase 2, 70% of them have transglutaminase 6.
Really?
Yeah.
Wow.
Other papers have found that 2/3 of people that have gluten sensitivity actually have reactions against their brain and have no intestinal complaints at all.
So they're dealing with the brain fog, depression, and anxiety.
And here's the deal. With that question now, researchers are saying that really the impact of gluten is really on the brain that it has ever been on the gut. It just happens to be that gastroenterologists found it first, and they classified it as a gut disorder. But really, now what is really happening is it's showing that it's a neurological disorder, and you usually don't even have gut manifestations.
This is such fascinating stuff, man. I love this. Lastly, diet. What kind of diet do you recommend? Is like paleo diet, or what are we talking about here?
Listen, for people, for brain,
yeah,
for brain gut. Listen, from the brain gut, let's talk about the complex pattern. Brain gut axis failure. Brain fails, so you got to get the brain healthy. Gut axis fails, now you have sensitivities to foods. So obviously, we know non-inflammatory foods are really the way to go, and we can say foods like gluten are off the table, wheat's off the table, and if you make it very simple, it's paleo, right? But here's something that we just recently did in our lab, okay? We went and made monoclonal antibodies, and monoclonal antibodies are antibodies that are produced that can only bind to one antigen and nothing else, okay? And
when you say antigen? Antigen
is the protein that they bind to. So you have proteins, and if you react against an antibody sticks to them, then your immune system destroys it.
Gotcha.
So with Dr. Vijdani and I, we got monoclonal antibodies for cerebellum and thyroid, and we went and checked TSH, T4, T3, TPO, Purkinje cells. We did it for the pancreas, islet cells, and GABA pathways, and we found many paleo food diets cross-react.
That's not good news. What are people going to eat?
So here's the deal. What we're fine-tuning now, and we're taking this to the next level, and this is going to be in the next year or so, is the next level is you find out which tissue antibody you have, and then you find out which of those foods cross-react with that tissue antibody. So for example, what we've mapped out now, we haven't published it yet, we just got the data back. It takes about another 8 months to publish because we have to write the manuscript and reference everything, and then who knows how many revisions we have to do for the journal to accept it, right? So, and we can't disclose the research because then we can't publish it, right? So here's the thing. Right now what we found is the next future model is this. You have thyroid antibodies, here are the foods that cross-react with thyroid. Now, what that means is more specific than paleo. Mm-hmm. But I'll give you one example. When we did our research, we found tuna antibodies cross-react with T3. So if you have tuna antibodies that are high, those antibodies can attach to your actual T3 hormone.
T3 hormone for what?
For the thyroid.
Gotcha.
It's the main thyroid hormone. And then it can bind to that T3 hormone and then cause your T3 to be destroyed. Okay? Now, it doesn't mean every single person with thyroid has to avoid tuna, but if they have tuna antibodies that are high, because they're sensitive to tuna, that reaction takes place. Interestingly enough, we checked cooked tuna and no reaction. And then we checked, another one was soy. Soy cross-reacted with the thyroid, but only processed soy, not actual soy protein.
So it's a great way to refine the paleo diet.
So here's the future if you're working with an expert. The future is, here's your tissue antibody. Here's the foods that cross-react. Let's check you for those foods. And if you have high antibodies with foods, you got to get rid of them. And that's going to be a fine-tuned way more than paleo. That's where our research is going right now. And we've dissected the thyroid pathway. We've dissected the brain cerebellar pathway, which is the most common thing for celiac. And we've dissected type 1 diabetes pathway.
When do you see that testing being available?
In the next year.
Very good.
Well, it'll be a food allergy test. It'll just be death-induced food allergies, then you have to match it up with the research we've done with monoclonal antibodies. And then that's where this game of just doing general diets is going to go away for autoimmunity.
This keeps getting more and more dialed in.
Yeah.
I love it. Very good. Your book is Why Isn't My Brain Working? Fantastic book. Your website is brainbook.com.
Brainhealthbook.com.
Brainhealthbook.com. Tell us about your book, because this is coming out in November, and so your next book should be on the way then, right?
Right. So our next book is going to be out before the end of the year, 2014, and it's called The Gluten, Leaky Gut, and Autoimmunity. And it's really a book where it's beyond just like, hey, gluten's bad for you, and leaky gut, take glutamine. Okay. It's really a book on really getting into the complexity of all these things and going, hey, here's all these different mechanisms of leaky gut, and here's why some don't heal, and here's all the most common tissue antibodies, and here's the vicious cycle, and here's what you don't know, and here's why some don't get better. It's really trying to take it to the next level instead of just, you don't eat gluten, take some glutamine, and go on a paleo diet. It is much, much more advanced than that.
Looking forward to reading it. Dr. Karazian, thanks so
Pleasure.
much.
Great stuff.
Thank you.